So, ladies and gentlemen, I will have a talk on safety rules when performing peripheral nerve blocks. And my objectives are to explain you a practical approach for a safe performance of peripheral nerve blocks. I will have as objectives explain you the stop before you block, the safety algorithm for avoiding intraneural injections. I will show you some, in short, the contraindication, and the whole purpose of this presentation is to show you that this is only a risk reduction, like wearing a mask during COVID. We published last year guidelines for the safe clinical practice of peripheral nerve blocks in the adult. This was done after reflection and looking at different literature in the world of regional anesthesia. And safety starts with information to the patient and to have an informed consent that is at distance of the block. I mean, that is not done 20 seconds before performing the block. The patient has to have some time to think about it. You need to register your block in a medical file. You need to respect the fasting guidelines because not all blocks will work, and in some cases you will have to perform a sedation or a general anesthesia. Therefore, you need an intravenous access for safety, and you need to monitor your patient. It's easy to organize a block room when you perform many blocks. In that block room, you need the related equipment and drugs, the resuscitation equipment and drugs, and of course, in those drugs, intralipid, and all has to be performed in asepsis. Information start with a brochure, and here we have some 3 types of brochures for the upper limb, for the lower limb, and for blocks for chest and abdomen. And in this information brochure, you need to be practical, to say how it will happen, to say what will the injection be like, what will happen during the operation, what are the advantages of a regional anesthesia technique, whatever, in this case, peripheral nerve block. Explain the side effects and eventual complication, but pay attention that you explain the frequency very clear, and a complication that is often like 1 on 10 is, say, it is someone in your family. And if it's very rare, 1 on 100,000, then it's someone in a large city. That's better to explain for the patient. Explain what are the possible alternatives. Tell them what will happen after the operation and the aftercare when they leave the hospital. You need to have a contact person in special situations, like if you put a catheter and the patient leaves the hospital with a catheter, and the patient needs to get the information they want to, like you can find further information on the website, or you can call the hospital and then you have to give them a phone number. Before performing block, you take some time, a stop moment, for checking the correct side and the correct side of the block. Why? To avoid wrong side blocks. And that's especially for unilateral blocks. It is a simple double check. Someone asks, we stop, and you check if you're at the right side. It is separate of the WHO checklist. It happens immediately before insertion of the needle, and it can be initiated by anyone, an anesthetist or a nurse or even the surgeon, if he's already in the room, of course. So, once you are performing your block, what are the prevention techniques to avoid a peripheral nerve injury? The conventional idea that an intraneural injection leads to injury. That's what all of us think. But we know that for in actual information with in the literature, an unintentional intraneural injection is not always associated with injury. And in 2006, Paul Bigelaisen performed a study where he intentionally performed intraneural injection. And he said that is to achieve a powerful block. I will show you that's perhaps not a good idea. And Neil in 2010 had the same question, is it really necessary to perform intraneural injection intentionally? What is the occurrence of intraneural injection when it is not intentional, when it is accidental? And we see that in retrospective studies, we have a frequency of 0.5 to 1%. These are accidental injection, and accidental injection are underestimated. The incidence is underestimated. And if there is an injury, it is mostly transient, subclinical, and if not subclinical, these are mild neuropathies that are gone within a few days to weeks. What about the occurrence and the technique used to perform the block? And we know that for many years, when nerve stimulator, the peripheral nerve stimulator was used, that nerve stimulation does not prevent intraneural injection, but that doesn't lead necessarily to an injury. So in a study of Aurora in 2002, all blocks done with peripheral nerve stimulator, they had 2.4 cases of severe neuropathy on 10,000 patients. With ultrasound, we can visualize the nerve, but we cannot see the fascicles. And there is actually no decrease in neurological injuries, but there is a decrease in the incidence of local anesthetic systemic toxicity. And that was shown in a study of Barrington in 2013. In his preliminary results of that study, he performed in peripheral nerve blocks in 7,000 patients and looked at the complications, and he said it was similar to those of Aurora and Capdevila, 4 on 10,000 blocks. But here there is some kind of problem. What is the power of this study when you see that you have 4 on 10,000 and they only performed 7,000 blocks? So can we have a statistical difference when we have rare complication, an incidence that is very low, and actually not too many patients? In this study, 2/3 were ultrasound-guided and 1/3 still with peripheral nerve stimulator. And in the literature, we see that there are 9 times more deficits unrelated to peripheral nerve blocks. And that was the same conclusion of Fredrickson. Most block neurological complications are a result of non-block related causes, mostly positioning during surgery. The difficulty is to find the incidence of neuropathies after peripheral nerve blocks. And the difficulty is because of the unreported cases. Why are they unreported? Because they are unknown. A lot of us perform peripheral nerve blocks, and actually you cannot see every single injection if it is outside the nerve or inside the nerve. So most cases it is unknown. Some physicians are not willing to report that they injected intraneurally. And if we inject intraneurally in children with a mild neuropathy, we don't know because they do not complain. So we have actually no idea of the unreported cases. And if you look at statistically, the true incidence of any unreported event can be as high as 3 on the number of blocks. So it is a statistical problem, and to change or to perform a better and safe procedure, you need, and to prove it is statistical significant, you need to perform a lot of patients to find a change from 4 on 10,000, let's say, on 2 on 10,000. You can do a multi-center study, but then you need a very strict protocol for every performer to follow. Otherwise, your study will be not valid. When we look at the type of peripheral nerve block associated with nerve injury, we see that more than 80% are located in the brachial plexus. And of those 80%, half are interscalene block, and almost the rest is for an axillary block. So that's quite important to know that. And let's have a look why that difference in upper and lower limb. And to understand that, we need to review a little bit the neural anatomy and histology. When we look at the left side, we have a brachial root with in front the motor nerves, and posterior the mainly sensory nerve axons. And it is surrounded by dura mater. And in between, we see cerebrospinal fluid. Then there is a transition to the peripheral nerve that we know with axons in a fascicle, fascicles surrounded with perineurium, and all the fascicles are in some kind of stromal tissue surrounded by epineurium. That's the nerve that we know. And we see that the more proximal we are, the more the nerves tend to be solid, because there are more axons, and the more distal, the more stromal tissue, the more dispersed the fascicles. The nerve is surrounded by epineurium, the fascicles are surrounded by perineurium. These are two tough structures, and the perineurium is so tough, and it is very resistant tissue, that it is unlikely to be penetrated by a blunt, short bevel needle. What happens if we have an intrafascicular injection? And I have to thank Xavier Salablanche for this beautiful histologic picture. You see a fascicle with a needle entry track and the laceration of the insertion of the needle into the fascicle. There is a syringe created by the intrafascicular injection, but a lot of the fluid is going out the fascicle in between the different axons and the perineurium, causing compression of the fascicle. And that's what we can see. But we cannot see the compression of the vessels with ischemia as a result, or the causing of a thrombus in a vessel, which also will cause ischemia. And what about the chemical-induced neuropathy? No idea, of course. We cannot see this under the microscope. In 2006, like I said, Paul Bigeleisen punctures different nerves of the brachial plexus with a short bevel needle and injected 2 to 3 milliliters of an anesthetic mixture into the nerve. But he injected only in 72 nerves. When you see that you have an incidence of 4 on 10,000, 4 severe neuropathies on 10,000, you can see that 72 is statistically very difficult to say that is the correct way to act, because in 72 you can perfectly have no neuropathy. Another study, 2011, from Savisala Blanche, they performed with a peripheral nerve stimulator an intraneural injection, and in only 20 patients, again, a problem of a statistical problem to have significance. This one of the group of Admir Adzik, 24 patients, they combined ultrasound, peripheral nerve stimulator, and pressure monitor for an intraneural puncture. They didn't perform an injection if the pressure was more than 20 psi. They proved that with the ultrasound, that with low current stimulations with response was an intraneural puncture. But I also saw that there were no motor responses in an intraneural positioning of the needle in 17%. But in these 24 patients, there were no neurologic deficits. This one is interesting because it was done in pigs, or only 10 pigs, but they saw that an intraneural injection caused an histologic injury, but not a functional nerve injury. And that, of course, is important to know. So now, how can we prevent an intraneural injection? Because that's the safety procedure and the purpose of this talk. Pain on injection is not a reliable sign. It is present in a minority of cases, and we see that some authors said that nerve puncture is usually without paresthesia, and it is possible to touch the nerve without any motor response when you use a peripheral nerve stimulator, nor a paresthesia when you put your needle against or you touch the epineurium. A discomfort while injecting is a pressure paresthesia, the pressure of the injected fluid around the nerve, and that seems to be normal. That's in a lot of cases, you will find that in an interscalene block. But still, we will avoid heavily sedated patients when we perform a block, because we want to have a response if there is something abnormal. And if there is some pain, we will stop to inject and ask what kind of pain or whatever the patient has to say. What about the peripheral nerve stimulator? What is the correct intensity of the stimulating current when we perform it in some years ago only for nerve localization? What is the optimal current current intensity for localization? And for those who performed blocks with a nerve stimulator, it is different from patient to patient, and it is different from nerve to nerve. What about the current intensity for a detection of an intraneural puncture. Again, this is very variable. And when we look at this unpublished data of Admir Radzik, where he looked at the nerve, the current intensity at 1 millimeter of the epineuron with the needle touching the epineuron and with the needle intraneurally, we see in the first two there is a decrease of the intensity when you are getting closer. But once intraneurally, you have an increase in some cases with, in 25%, no motor response with high currents when the needle tip was intraneurally. So that doesn't mean that the current, a low current, will give you a motor response when you are intraneurally. So as a safety rule, if we have no motor response at 0.3 milliamps, as I said, we can be intraneurally, but probably extrafascicular. And Choquet said, do not search for a nerve response with currents of 0.3 milliamps or less. So actually, the rule is use a current of 0.3 to 0.5. If you have no motor response, you can inject probably safely. What about pressure monitor or a pressure limitation device? Well, in a study from Adzik in 2004, he looked at the injection pressure when he was perineurally and injection pressure when he was intraneurally. And what you see is an increase of most of the pressures when you are intraneurally. High pressure could mean that you are intrafascicular. And he performed a study in dogs where he looked at the injection pressure. When he was at a low pressure of less than 5 psi, he was perineurally, and the block lasted for a few hours. When he injected intraneurally with pressures of less than 12 psi, he was probably intraneurally, but not intrafascicular, and he had a block that lasted much longer. But once he injected intraneurally with high pressure, he was probably intrafascicular, and then he didn't see any recovery after 7 days. So his conclusion was that a combination of intraneural injection with high injection pressures could lead to fascicular injury and a neurologic deficit in dogs. In a study of Christopher Mellon, he looked at the opening injection pressure in fresh human cadavers in blocks of the lower limb. And his conclusion was that monitoring the initial injection pressure could be useful in detecting and eventually in preventing intraneural injection during nerve blocks. So what kind of pressure monitor do we have? We have this kind of pressure monitor where when your initial pressure is more than 20 psi, you stop your injection. The problem of this device, you have to look at it. You need a person, the person who is injecting, to look at that monitor and not to look at the screen of your ultrasound machine to see where we are injecting. So the person who is performing the block can only look at the screen. The person who is injecting has to look at the monitor. Besides this, there is a pressure control device where the pressure is limited at 15 psi, and you don't need to look at it. If you can't inject, the pressure is more than 15 psi, and then you have to move your needle and to see if you can inject at a lower pressure than 15 psi. So easy for people, for anesthetists who are performing the block alone, let's say, where they can keep the syringe in one hand and the probe in the other. What about needle design and direct trauma? Sharp needles have a high risk of nerve penetration and, of course, of penetration of the perineurium, and with the risk of an injection intrafascicular. The sharp needles have a clean cut, and the lesions are not so severe if you don't inject. Blunt needles reduce the risk of a nerve penetration and fascicular damage, because it is, like I said, very difficult to penetrate the perineurium. And like I said before, the nerve injury will be less if there is a needle trauma without injection, without compression. But the needle also has to be visible. It is not only a blunt needle, but it has to be visible. And the visibility is, for most of the needles, perfect between 0 and 45 degrees. But your needle needs to be visible for blocks at steep blocks, deep blocks, when your needle has to go to 60 degrees or even more. What about ultrasound? With ultrasound, we can visualize the nerve, but we don't see the fascicles. It is difficult to see the epineurium. Needle penetration is not always visible, and in a lot of cases, even not at all visible. What about intraneural injection of local anesthetics? Well, Moyari proved that you could reliably detect an intraneural injection when you had a swelling of the nerves with 0.5 ml of your local anesthetic solution. And with ultrasound and peripheral nerve stimulator together with a stimulating current of 0.3 to 0.5, you cannot rule out an intraneural position of your needle. So what are our possibilities? Well, we would like to put our needle perineurium, outside the epineurium. But accidentally, we can pass the epineurium and inject in the stromal tissue, probably without consequences. If you advance your needle accidentally in a vessel, you can cause a bleeding with compression, but you can also cause an occlusion with ischemia. And if you put your needle farther and you perforate the perineurium, you are intrafascicular. With the tough perineurium, you will have a severe compression in the fascicle with probably severe lesions. When we look at a median nerve under the microscope with a magnified, 40 times magnified, you see the different structures, the small vessels, the epineurium, the perineurium, the fascicles. The same nerve under with ultrasound, with the magnified 4 times, and you don't see all these structures. So it is very difficult to say, I am in a fascicle, even I penetrated the epineurium. So we performed a study where we looked at 2 different approaches with our needle, a direct, straight to the nerve approach and a tangential approach in a cadaveric study. And the way it was done was this way. We have a direct perpendicular to the nerve approach, and we have a tangential approach, so at the side of the nerve. And what happens in those 2 approaches? When you have a direct approach, you put your needle at the edge of the nerve and you advance 1 to 2 millimeters to simulate an accidental advancement of your needle. And we see that in a lot of cases you have a puncture. When you perform a tangential approach, you put your needle at the edge of the nerve, you advance your needle of 1 to 2 millimeters to simulate again that accidental advancement, and you see there is a rotation of the nerve without penetration of the epineurium. This is visible on this movie. We are approaching the nerve, we advance a little bit, and there is a rotation of the nerve without penetration of the epineurium. So the conclusion of that cadaveric study was that if you have an accidental advancement due to suboptimal conditions, like you are a beginner, you have a deep nerve with bad resolution, it is safer to do a tangential approach, and you will have less risk of intraneural injection. So in the safety algorithm, we identify the nerve in short axis, we look at our needle tip, we advance tangential to the nerve, we avoid paresthesia, we avoid a motor response with our peripheral nerve stimulator at a current intensity of 0.3 milliamps or even a little bit more. We avoid high opening pressures. We assess the local anesthetic spread, and we evaluate our block before surgery. But I will show you now a movie of an axillary block. You will see in red the axillary artery and in white the median nerve, and it is an out-of-plane approach. The needle is not visible, but you see the pressure of the needle going in between the nerve and the artery. Then there is an injection in between both structures. The colleague who is performing the block moves his needle, and you see there is an intraneural injection with some kind of explosion of the nerve without neurologic deficit. It was a tangential approach. So once you perform this, even a tangential approach doesn't mean you cannot perforate the epineurium. But there is more. What about incidence of a wrong injection in regional anesthesia? So for avoiding chemically induced neuropathies. And the World Health Organization identifies tubing misconnections as a patient risk. And so they are for 20 years looking at avoiding catheter and tubing misconnections. And that leads us to the ISO rules, here in this case for neuraxial blocks, where you have different lure connection for every kind of injection. The NRFit design. Here in this case for neuraxial products, you have a smaller lure connector of 20% and and it is longer with 3 millimeters. The male cone has an additional edge, and the ISO, according to ISO, it is a yellow color. For peripheral nerve blocks, the same. The yellow color of the connection, in this case, the nerve guard, the nerve limiting, pressure limiting device with the same color. What about local anesthetic systemic toxicity, also a possible cause of problems, big problems? I will be short. You have to look at prevention. That means you need to know the maximum doses and avoid mixing local anesthetics, because then you have no idea of maximum doses. Be aware of symptoms and signs, and you need to know there is a therapy. You need to have the equipment, and you need to have the lipid rescue flow chart. Here is an example. Will be short with the rules to when you have a suspicion of toxicity and the administration of lipids. Short word on contraindications, respect them because there are some absolute contraindications. The refusal of a patient to have a block is an absolute contraindication. Allergy to local anesthetics is very rare, especially for amides. Injection of the puncture site, infection of the puncture site, absence of resuscitation equipment, incompetence of the physician is, of course, an absolute contraindication. The relative contraindications are a pre-existing neuropathy. If it's absolute, you cannot perform a block in a patient with diabetes. A systemic infection, I think a single shot block is perfectly correct to perform. A catheter can be a problem if you leave your catheter for several days. Epilepsy is relative. Hemostatic problems, again, is relative. And a risk of compartment syndrome, I think that's not the block, but it's the way you follow your patient afterwards and the solution you inject. If you use low doses of local anesthetic, you will have less problems. So in conclusion, this presentation is to show you that we cannot avoid all problems in regional anesthesia. It is a risk reduction. And we know that the complications are rare, but the consequences can be very, very hard for the patient. We need to prevent wrong side blocks so that therefore we have the stop before you block. I showed you the prevention strategy to avoid intrafascicular injection, the ultrasound with a blunt needle, the peripheral nerve stimulator, the tangential approach, and the pressure monitor. And to avoid chemically induced neuropathy, I say avoid, prevent, because NRFit is for the connection, but if you take in your syringe with NRFit the wrong drug, then you can also have a chemical induced neuropathy. So thank you so much for listening, and if you have some questions, I'll be happy to answer them. Thank you. I have some comments to finish this presentation because I don't see any questions at the moment. It is important to know that we cannot avoid peripheral nerve injury. This lecture was, and I would like to emphasize, to show you how to minimize the risk. And the risk can be minimized when you use that algorithm, of course, but also with a gentle and careful manipulation of the needle. That is mandatory if you are let's say with a brood, let's say, then it will be a higher risk than if you do it gently with a good visibility of the nerve on ultrasound. I think the risk is even less. And a small comment on can we perform this in a sleep or awake patient? Well, again, the difference between the two is a different technique. And it is a statistical problem to prove if one awake or the other asleep is safer. Again, you need to have a lot of patients to prove that this technique, awake or asleep, is better. And like I said, in an awake patient, you can ask for pain or paresthesia, but that's not reliable. So again, the same algorithm in sleeping patients with a gentle manipulation of the needle is mandatory, and probably some more experience. I see, do you feel, in your opinion, do you feel a risk of compartment block is a contraindication? Well, when, like I said, and we published a paper a few years ago on a case report on a compartment syndrome in a child of 4 years old who had a surgery of the forearm and who had an infraclavicular block with a catheter. And there were actually no problem to see that the patient, the child, was at no pain after surgery, and during the night pain increased that the child didn't eat and didn't play. And that was a reason to say, oh, the child has more pain than after surgery. And ischemic pain is painful, more painful than after post-surgery pain. If you use adequate low concentration drugs and you follow your patients regularly, normally there is no problem for a compartment syndrome to detect a compartment syndrome. But there are some case reports on compartment syndrome and regional anesthesia, and actually for me it's not a problem. You need a good pain service. I don't see any other question. Okay. Do you think that triple control pressure stimulation ultrasound can improve safety in regional anesthesia? Yeah, that's what I told. I think the use of the different components, pressure, stimulation, ultrasound, and tangential and gentle manipulation are all the things to improve safety. And I think for those who are performing neuraxial blocks, it's the same. You don't need ultrasound, you don't need a pressure monitor, you don't need stimulation, but again, gentle manipulation of your needle is probably the best thing for safety. Many prefer to self-inject and many allow the nurse to inject. Does it make any difference? Well, the advantages of a nurse is that you can keep an eye on your ultrasound screen, and you don't have to, where is my syringe? Because in one end you have your probe, one end you have your needle. If you are very handy, you can take the probe and the needle and in one end and the needle and the syringe in another end, but still you cannot see how much you are injecting. And I think a nurse with a pressure limitation device can do perfectly the job. She can tell you, when you are looking at the screen, I injected 2 cc, I injected 5 cc. So it makes it's for me an advantage to be with a nurse, with another colleague for a peripheral nerve block. No other questions? So I would like to thank the audience, and I would like to thank Pajunk for giving me the opportunity to give you this lecture. So thanks all of you, and bye-bye.